to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Patricia Fogelman. She is a nurse practitioner and she has a doctorate in nursing practice. And she wrote the Kevin MD article, A Soul That Never Loses Faith. Patricia, welcome to the show.
Thank you. Glad to be here today.
So we'll get into your article in a little bit, but first off, just share your story and journey to where you are today.
Sure. I always tell people I've had a ridiculously blessed process through a career in medicine. I was a staff nurse in an ICU. I was then hired as a nurse practitioner into the pulmonary practice of our ICU, pulmonary ICU physicians in that unit. And then from there, because of our work with so many of our advanced lung patients and our partnership with the thoracic surgery group, was recruited by our local thoracic surgeon to come to Columbia University, where I was the clinical chief of the lung transplant program, helped grow that and got it, CMS aligned and Blue Cross Blue Shield Center of Excellence, all those things. We got our market share up in transplant volumes. And then I met my husband, who's from Central PA, and made a move to Pennsylvania, which again, another fortunate opportunity where I sent a letter to the recruiter at a regional medical center, got this opportunity, to start working there, was then recruited into palliative medicine and, kind of grew my career there under the mentorship of Dr. Neil Ellison, who is a chairman emeritus now of palliative medicine. And from there, I was actually recruited here to my current position at Guthrie, which is a rural integrated health system in the northern tier of Pennsylvania and the southern tier of New York. And I'm now the system medical director of palliative medicine for Guthrie as the healthcare system, and manage palliative medicine delivery across 3 hospitals, 1 kind of critical access site, as well as our outpatient clinics.
So walk us through a typical day and maybe tell us some of the challenging cases that you see on a daily basis.
So palliative medicine is this fascinating entity, right? You've got to be comfortable kind of being in a gray space with patients. And I think what brings a lot of satisfaction to our work here is that we are able to kind of walk our patients through this chapter, whether it's managing their symptoms as they move through cancer therapy so that their nausea and pain are controlled and they can complete their therapy and come out on the other side. Sometimes it might be the critically ill patient in the ICU that you're having critical illness conversations about, establishing the goals of care, or perhaps meeting with their families to kind of talk about compassionate extubation. I think these last 2.5 years with COVID has really evolved the practice of the integration of palliative medicine here with the critical care services. And our presence in the ICU has really evolved over the last 2 years, as a result of that, both in part because we've had very supportive leadership in the ICU that welcomed a partnership with us, but also because I think the need for integration and the engagement and collaboration with palliative medicine just really started showing a clear efficacy, a clear benefit, having us kind of embedded and engaged in the COVID ICU, for example, gave the ICU team more bandwidth to deal with the acute issues that they needed to deal with. And then we kind of took on the majority of the responsibilities for the communications, the goals of care and family discussions, family meetings. And then, all too often, if those patients went towards a palliative extubation, then we would handle that as well and kind of continue that support. So it was a really good collaborative practice that we've managed to evolve here.
So you talk about that evolution between palliative care and critical care medicine. Now, what was it like before that evolution, just so I can give my listeners a sense of a before and after picture?
So when I was recruited here to build the palliative medicine program, so prior to my arrival, there really wasn't a structure or a process. There was a half-time nurse practitioner who also was a split with oncology. We were part of the cancer service line, so a lot of our work is engaged with both critical care and oncology. And, there wasn't this kind of process, like how do you direct patients? How do you identify them? What should be the trigger criteria for referring patients to palliative medicine? And should there be a process really for earlier involvement and engagement in the ICU? So coming here, there was a lot of things on that to-do list, but within the first 6 months, one of the things I'm often really the proudest of is that our engagement with providers and provider satisfaction improved close to 90% with the surveys we did. And we also kind of established a very visible presence through the system. And part of that is really engagement and embedment. So being in the ICU, present consistently for team rounds several days a week, meeting with our hospitals team once or twice a week for huddles, particularly in our high volume med surg floors. I also implemented, I call it the Palliative Medicine Acuity score, but it's a daily report that I run that looks at several different elements of a patient's medical issues that gives me a score of up to 9. And that kind of triggers a palliative medicine consultation. And so I look at those who are scoring 5 or higher, and I review those charts. And then, really, if they're highly appropriate, we'll often reach out to the team to say, this patient is scoring very high on our inpatient acuity report. If you agree, would you please consider ordering a palliative medicine consult? And what we've seen in the last 3 years almost is that the total percent of patients with a score over 5 that have an existing palliative medicine consult has steadily been increasing. So I think that's evidence of outreach, education, and just that steady presence, kind of demonstrating performance and accomplishments that are showing that the culture and the awareness and the understanding of how palliative medicine can engage and assist has really come forward here. So that's been some real progress for us.
So what are some things that go into that score that you're talking about?
So we look at a couple of things. We look at elements of frailty, fall risks and things like that. We look at their nutritional status. We also look at, for example, how many organ systems have an advanced illness or are in a state of failure. And so, we may have, for example, a patient with multiple hospital admissions in the last 3 months, plus minus falls, plus minus 2 or more advanced illnesses, such as advanced heart failure or COPD or diabetes or renal failure, vascular disease. And then we look at those other factors as well. So the nutritional status, their frailty score we throw in there. And so we're really just looking to see, what the combined score is. We did have it initially set at 4, which I thought was particularly ambitious at the beginning. And what I was capturing, honestly, was just too high a volume for a team of 2 providers to support. And some of that, honestly, was almost like a little bit on the low-hanging fruit side. So they didn't really measure, it wasn't capturing the true measure of like inpatient acuity need. And so we bumped it up to, let's say, a 5 or higher. And that's when we really started capturing these high need patients. And so those scores are allowing us now from a setting of like ICU, med surg oncology to see these patients sooner, to start these dialogues sooner, and to really be part of an intercollegiate team for these patients so that they have a true sense of what a multidisciplinary approach to their care is. And I always try to reinforce both to our residents, our nursing students, and our provider teams that, we're taking care of a whole person when we're doing this. But that whole person is an entity that includes families and caregivers, right? So it can't just be that we go see this patient, do this care, write a note and leave. It's also that we engage with these families and these caregivers and provide these updates and have these ongoing conversations about what are your concerns? What are your additional questions? What do you feel we haven't attended to? And frankly, sometimes it's just coming out and asking, are there other things that maybe we could be more respectful or mindful of for you, or for your loved one? And are we missing something? Are we not doing something right to your liking? And so it's a real opportunity, to kind of get us involved earlier. And I think that, overall satisfaction scores you see start to trend up as well.
All right, let's transition and talk about that Kevin MD article that you wrote back in February. It's titled A Soul That Never Loses Faith. Now, for those who didn't get a chance to read that article, can you just walk my audience through it and share the story of why you decided to write it?
So we have had, 2 heavy COVID surges, and this most recent one this past fall to winter was particularly intense. And part of that response here, really required me taking a critical look at our team. Again, it's a team of 2 providers. And how do you leverage your resources in an equitable way? And, we're part of the cancer service line. Our clinic is in the cancer clinic. We are in and out of these settings with immunosuppressed patients. We also have a very heavy presence on the inpatient oncology unit. So when I kind of sat down saying, how do we kind of do this in a way that makes sense? One approach was to really say, okay, we're going to kind of split us into teams, right?
Mm-hmm.
And so one of us will cover COVID ICU and the COVID floors, and then main ICU and ED, and then the other person could be like the non-COVID cases, so the oncology cases in particular, as well as outpatient clinic, and then regular med surg. And we varied the timing of that a little. Do you do a 1 month rotation? That proved to be a little too intense for some of us. And then we tried 3, and then 2 weeks kind of hit on the right balance. So 2
Mm-hmm.
weeks at a time of COVID. And that gets you kind of through most of these initial conversations, establishing a rapport with families and kind of getting some goals often delineated and identified. And so this particular case that I wrote about was a case I had been following for several weeks. It turned out to just, for me at that time, be about a 5-week rotation on covering all of our COVID units, just due to some staffing issues and things. And this case was very, very poignant. You know, we had a very young man who had recently completed cancer therapy successfully, you know, and had come out with a clearance of his cancer. And, you know, young family, chose to kind of go out and celebrate New Year's with a few friends, very, you know, safe, fully vaccinated, kind of in a safe setting. And then unfortunately contracted COVID. And, you know, whether it's from going out on New Year's versus just being out in the community in general, I think that's really hard to pinpoint. I'm not convinced it was just the New Year's. It's just, he also worked full time. He also, you know, was active in a variety of things with his children. So I think there's a lot of potential places where exposures could have happened, but it just, despite every effort we made, could not get better. And, you know, we at one point thought, okay, maybe we should try to get him to a higher level of care, maybe ECMO, but then, you know, with a very recent cancer, he was not a candidate for those types of things and was not a candidate for lung transplant. And then just really became too sick at that point to kind of send anywhere. And, you know, so we're having these very intense conversations with family on an every other day to everyday basis. We're conversing about the changes we're seeing, what we think this might be indicating to us, what direction this may be going in. And we're working with this family to kind of say, where are your boundaries and where are your thoughts going? And it was a really lovely family, you know, very, very, very honest in their perception of the situation, and kind of like, we hope for the best, but we're also preparing for the worst. And then one day, you know, the worst news came. He was in florid multi-organ failure, you know, high pressure ventilator settings. Nothing was improving. He was clearly accelerating to death. And, you know, we had to have a very hard meeting. And I think when you are embedded in these situations, in these environments with families, and you have these long trajectories of contact over weeks and weeks, especially because your team is the same team, your nurses, your critical care providers, our resident teams, like we all had this very vested interest, you know, in this family and in this patient. And, you know, part of compassion and caring, I think, is that we invest in our care of our patients. And, you know, it's just all around just an exceptionally difficult experience. But what stuck out the most for me is that even though we did this work that was so terribly painful and so difficult and just, you know, unrelenting, you know, it's like this battering ram of sadness sometimes. We really kind of, as a team, had this sense of like, you know, we're going to keep doing this work. This is important work. We're going to care for each other as well as we're caring for our patients. And, you know, that's what kind of led to that title. It's that we, you know, you always want to pray that you have eyes that see the best in people, a heart that forgives the worst, and a mind that forgets the bad. And then as a result of all those things, it's a soul that never loses faith, right? And so that's that culmination of that hope. And so that experience was just, you know, very, very, it was very vital, I guess, just very intense, and just bore kind of bringing forward, like, of all the things that COVID has taken from us, how about we talk a little bit about what it hasn't taken? And, you know, what I'm seeing here with our teams and with our nurses, our critical care docs, our residents, my team, my providers, is that it has not taken our compassion. You know, it has not taken away our love for humanity and our ceaseless curiosity in the human condition. It has not taken from us this desire to continue to do good work. and to care for these patients. And rural health especially has this appeal of you are often caring for patients in your community.
Mhm.
So it is not at all uncommon that you could take care of a patient or a family in the ICU and, weeks or months later, see them at the grocery store, because this community is a smaller knit community. And so it's not at all uncommon that you're going to have these ripples of connections, to others through the community, or you're taking care of someone and you find out they're related to someone in the hospital, or that person contacts you and say, you're seeing my uncle, or you're seeing my granddad, and, can I be part of that meeting? Can I be part of that discussion? So I think it just kind of became important to kind of bring some attention to the things that COVID didn't take from us, right? I think that it's been hard to watch the attrition in healthcare personnel, particularly in nursing. It's been hard to watch the burnout and the fatigue. I think feeling, that public pressure of that tide turning from being like kind of pro support of healthcare providers to now kind of being like, well, you're perpetuating the problem because you guys are, pushing an agenda, or, vaccines not the answer and things like that. But at the end of the day, like all those things to me, like kind of fall away at the bedside of the patient. Like we're here to care for the person in the bed, and your choices up to that point, or your decisions or whatever, aren't what I'm here to judge, right? I'm here to help you as best I can. And we're going to do our level best, to make things better, but know that sometimes, despite our very best efforts and our very best technology, we can't. And I think people also mistake that. They think, oh, rural health, you don't have a lot of tech, but this is a really top-notch, high-end, medical center. And we have a shock trauma program, and we have a very, very lovely ICU with, all of the top technology. We have a super, involved, engaged, and breadth of service cardiovascular service line. So, we offer some pretty sophisticated care for such a rural area. And I think that that's a really phenomenal stroke of fortune to be able to do that kind of work and to be able to serve a community this rural, because I don't think that happens in every rural community. But this is the same care everyone deserves, right? And so I think it's also the flip. It's the care everyone deserves, but as the care providers, as a team, this is also the care and acknowledgement we deserve, to kind of remember that despite the very tough things happening in these tough moments, and there was a recent quote by Brene Brown that kind of said, these are the tough edges of love. When you're in these conversations, and palliative care really engages in those tough edges of love. And I think that's really what we've all kind of stepped back as a team and said, yeah, this work we do, a lot of times this right here, these are the tough edges of love, because these are patients who are critically sick. They're often the sickest and most vulnerable people in our institution. And we're doing everything we can to really try and help. And some days that's make your pain better and relieve your breathlessness. Other days it might be helping you fill out an advance directive so you have some resolution and peace, that you have a plan of care in place. And other times it might be opening the door to a super difficult discussion that you haven't been able to kind of effectively have with your family. And so we navigate that for you. So I think that, we're very lucky to have this huge range and scope of stuff we could do and just derive so much satisfaction from.
Now, whenever you talk to families, of course, in the palliative care setting, a discussion with one family may be completely different with a discussion with another family. What kind of questions do you ask to get a sense of that particular family's values that may influence their decision making?
Now, I always ask questions to give me several pieces of information. One is to always kind of find out, how do they like to receive information, right? So some folks are really high information seekers, some may be more middle of the line. What I also ask is kind of, tell me what your understanding is of where things are at right now. So are they on the same page? Do they have the same information that I have? And if they don't, that's a starting point. So let me tell you what I know. And let me tell you, what my updated understanding is. And sometimes it's just a very simple question. I'm known in my space for being the person that asks the question, and my residents will tell you this. A lot of times I start off meetings with a very simple, if I told you you're pretty sick and it's pretty serious, would you agree with me? And I kind of just put that out there as kind of the first question. And, most of the time people really say, oh, no, I'd agree with you. I think so. And sometimes they're just like, no, I don't think so. And so then that gives you a sense of where the disconnect might be and where you might need to kind of start with the information providing. And and, bring things to bear. But those are the things I like to try and suss out, at the beginning. And then as the meeting goes on, I usually also want to kind of know, because again, this is whole people caring for whole people, as Ira Bayek says. And so it's important to know what are the things that are important to you as well. Like, is there something, for example, from a religious or cultural perspective that I could be more mindful of? And if there is something, how can I do that for you? Who can I call or who can I ask for help to make that better? Or is there someone I can call for you? Sometimes it's reaching out to, their own spiritual care community or one of their designates to kind of say, can you come see this patient for this family? And so I think that that's the type of information you want to at least try to get. And if you're going in to deliver some bad news, so for example, you're going in to tell someone that their cancer has progressed, or that, chemotherapy may no longer be an option because of this progression, then also to kind of go in there and be ready to kind of deliver a warning shot a little bit and try to prepare people and just say, this could be, kind of a difficult conversation. And do you have everyone here that you would want to be part of a conversation like that? Or is there other folks that we should include or call or have present? Sure. And how should that be for you? Because I don't want you to feel like you're hearing a lot of information and getting overwhelmed and then feeling alone or struggling with isolation. And so those are those preemptive things I think that are just as important as the actual meeting itself.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Yeah, I think the take-home messages are always, from the perspective that palliative medicine is certainly here to help engage in the care of the advanced illness patients. We are another division of medicine, another subspecialty. We're all board certified in this. We've had various career trajectories that got us here. One of my partners is a hospitalist who then pursued palliative medicine. My background is pulmonary critical care, and then I segued into palliative medicine from there. And another one of my providers is primary care and moved into palliative medicine. So I think we all kind of bring something to the table that kind of shape those experiences. And I think the second thing is to just really remember that as healthcare providers, I've never experienced in my life a time where taking care of ourselves has been more important and more vital than now. And it's also at the same time a period of life where it's difficult to care for ourselves, maybe as well as we need to or should. But there are countless resources out there. The Center to Advance Palliative Care has an entire COVID-19 resource webpage, and it's all free. There's no membership required. And in that actually is a great section called Emotional PPE. And, I pull from there when needed. And even just the experience of where do we stand on our team? How do I bring them back and ensure their resilience? And so I meet with everyone individually every once or every other week, or every once a week. We do some time together once a week to reconnect. So it's often a lunch and sometimes it's quick, or we kind of spend a little time at the end of our morning IDT, kind of doing a quick debrief. And if any one of us seems to be struggling with a case or having trouble with a family or just clearly starting to a point of some frustration, another person very quickly says, let me take that family meeting for you. Or let me see that patient for you today. And can you see this one for me instead? Or can you see this clinic patient for me instead? And we're sharing that work burden. And I think we've been really good about protecting ourselves from a resilience perspective so that we can continue to do this work. And so that's really that big takeaway, to remember to invest in ourselves and to care for ourselves so that, we can take the best care of others.
Patricia, thank you so much for sharing your stories, time, and insight. And thanks again for being on the show.
Thank you.